The Next Breast Thing podcast is primarily funded by the American Society of Breast Surgeons. The support of sponsorships helps us offset some production costs. ASBRS does not endorse or co-promote any company, product, or service mentioned.
This episode of The Next Breast Thing is made possible in part through the generous support of Solventum Prevena Therapy and Mammotome Breast Cancer Diagnostics and Surgical Solutions.
Solventum Prevena Therapy has demonstrated a significant reduction in surgical site complications, infections, and readmissions. Take a proactive risk management approach. With Prevena Therapy, learn more at Prevena.com. That's Prevena.com.
At Mammotome, we offer a comprehensive range of products that deliver better outcomes in breast care. From biopsy to surgery, our advanced technologies empower clinicians with precise, trusted solutions. Together, we will transform the future of breast care. Learn more at mammotome.com.
Hey listeners, want us to let you know when new episodes are available? Simply hit the subscribe or follow button on the Next Breast Thing podcast wherever you listen to podcasts. Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook. On this episode of the Next Breast Thing,
Did fly fishing, which is very relaxing, but it's like...
Here's what I did find out is that a boat with a hole in it is currency.
gotten back into Pilates, reformer Pilates.
And then I went to another neighbor's house, and on their patio, they had these like hummingbird helmets.
Our topic, surgical treatment for metastatic breast cancer. How often in the U.S. are we diagnosing de novo stage 4?
Is it 6%? To be honest, I kind of thought this topic was done, that we kind of had figured out that surgery...
I'm with Carla. I thought this was put to rest.
Yep.
But it's not.
That's been one of the hardest lessons I've had to learn starting out.
I have told patients that I'm not the right surgeon for them because I am...
Sometimes you get differential responses. What happens in the breast may not be what's happening in the bone.
Talk about the 2108 trial and the results for us.
This is Carla,
Ellie,
Michael,
Susie,
and Susan. Welcome to The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the entire breast community.
We're a group of devoted surgeons from different parts of the country,
inviting you to journey with us into the science of breast
through the heart and soul of our breast community.
From advances in procedures and patient care to personal transformation, we're here to support you.
So, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.
Our topic today is surgical treatment for metastatic breast cancer. This is a really important topic, and I'm so interested to delve into what everyone thinks about this. But before we get started, let's begin with personal and professional updates. Ellie, what's new with you?
So I actually just got back from Joshua Tree. I ran to make it to this episode. We just also started scouting new sites for our second property, and we're thinking maybe the Big Bear area or like Arrowhead. Big Bear, I don't know if you guys have ever been, but it's really beautiful. Like Carla was talking about, it's a trip where like your cup is full because I relaxed, I hiked, I did fly fishing, which is very relaxing, but it's like whipping a monochrome around, so it's very hard, actually.
I love fly fishing.
Yeah, it's super soothing. It's beautiful.
You just sort of get into that rhythm.
Yeah, it's awesome. Elegant. It's a very elegant way to fish, which is not what I grew up doing.
Did you catch anything?
I did like a little thing, but I felt very accomplished. But
Michael, do you have this on the...
No, I've got to get another...
On the boat?
I've got to get another lake because I do not leave my lake recharged. Here's what I did find out is that a boat with a hole in it is currency. So I got a guy to trap my beavers. Oh, no! And I traded the boat with a hole in it for a beaver. Oh, no! So basically, I'm now a trapper now, I guess,
Is
indirectly.
the boat with the hole in it
He pulled it up.
shipwreck that becomes
No,
a
it
little
was
reef?
it was in the boathouse floating, and then I came back and it had sunk. And I didn't know how I was going to get it out. But then the beaver guy comes up. Oh, no! And I said, look, if you get this beaver, you can have this boat. And he says, deal. Somehow, he pulled it out, took the boat, and showed me the tail of the beaver that he trapped.
Did he get the boat before he got the beaver?
He got the beaver first. I paid him with the boat. Just the going rate of a beaver is $40 though, but it was going to cost me that much to pull it out.
So is it just one beaver?
They're like in a herd or something. I don't know what a flock of beavers are.
A family that you broke up? I don't know. A family?
If there's more trees down, I've got a flock of beavers.
I'm looking up, are beavers individual animals?
They're herds. While you're looking that up, Carla,
family.
I'm pivoting to Carla because...
Colony of beavers.
All right, Carla.
Well, yeah, that's quite it's always the transition. I love following Michael with the updates. I don't really have a lot of updates. June was a quiet month for me and kind of enjoyed that because we talk all the time, right? I'm so busy. And June was quiet. And so I have gotten back into Pilates, reformer Pilates, and I'm really enjoying that. My body enjoys it as well. And I'm a big reader. And I just want to tell people I just finished the Calamity Club.
Oh my gosh. Amazing.
What is
it's the woman who wrote The Help. So
wow, amazing.
I read the book, but the movie was out. But it was one of those, I'm in a book club. And so we discuss things. And yeah, I enjoyed it so much. So I just want to recommend it.
What's it called?
The Calamity Club.
Is it sad like The Help? Like be like heartwarming?
No, I think it's a good book. And I laughed a lot of fun characters, but it's a very strong women book and long. I listened to it on audio and highly recommend it. It was one of those things where I was finding things to do just to be listening to audio. So I was taking walks and doing dishes, and I actually do pretty well and probably am more productive when I have an audiobook.
Audio is amazing. The characters, the voices, and Carla, the same thing happened to me. I could not find enough stuff to do. And it's long. It's well over 20 hours.
That's like 2 weeks of commuting for me.
Yeah, I did it like in a week. I was very busy.
Yeah. Well, what else have you been up to, Susie?
So wait, before we get into Susie, just for our listeners, Ellie and I wrote, and you could see us both writing the name of the book down. Michael just didn't move.
I only read studies.
Michael went book?
I study 9343 and Prime 2. I just read those over and over and over. I do not read for pleasure.
So we know how we think about this podcast well beyond it. And we think about some of the things we talked about. Well, I thought about Carla and her birds. And one of my patients was like, I have that birdhouse. It is amazing. And that's very safe. Yes. And she could not say enough things about it. Also young and hip, by the way.
Thank you. Similar to me.
Yes, very similar. And then I went to another neighbor's house, and on their patio, they had these like hummingbird helmets. And it has a feeder. So there's a clear glass over your eyes. And then they have a little feeder. And you just stay still. And the hummingbirds come and feed right in front of your face. And I could not stop laughing seeing all these men and women in their 50s like putting these on and being as still as they could to see these hummingbirds.
That seems just the most unsanitary thing you could ever put on your head.
They're very cute. I was in the city, and yes, there's only one, the city. Last week,
Pigeons.
And there was this one block in the village that every tree had a little birdhouse on it. Now, I don't know who put the lid, and they were all different colors. It was the coolest thing. I didn't see any birds, but it was the coolest thing just to see these little birdhouses.
Do they have rat houses in the city too?
First of all, thank you for acknowledging that it is the city. There's only one.
It's not a great city. It's just the city.
Well, it used to be a great city.
Is that was Ratatouille took place? I mean, that's
Paris.
Oh, that was in Paris. It's having some tough times these days, but we'll get back. I don't live in the city. I just visit.
Oh, absolutely.
I don't live there.
Live out in Connecticut.
So as Michael continues to pick on me, let's move on to our topic, surgical treatment for metastatic breast cancer. For many years, the role of surgery in stage 4 breast cancer was relatively straightforward. Systemic therapy to control disease and surgery reserved primarily for palliation. But as systemic therapies have improved and patients are living longer, the question of when and if surgery should play a role has become much more complex. Today, we're discussing the current evidence, the controversies, and real-world decision-making surrounding surgical management of the primary tumor in patients with metastatic breast disease, or breast cancer, really. So let's start with Carla. How often in the U.S., and it's different in the U.S. than other countries, thankfully, how often are we diagnosing de novo stage 4?
Ooh. Is it 6%?
Yes, it's about 6%. Compared to other countries, you go to India, it's greater than 50%. It does show screening works. We do have lower stage. When we talk about this topic, it's not for the masses. It's really for a very small number of patients, thankfully, but really complicated. So, Carla, you've been doing this a while. What changes have you seen, and how has your approach to de novo metastatic disease changed?
Great question. And I was really excited to talk about this topic. One of the big papers and clinical trials that was done in our country was the ECOG Akron 2108. I know we'll talk about that. Part of the reason I bring that up now is because I enrolled, that was the first clinical trial I opened as a faculty member. And part of the reason that that trial was developed was because, as we all know, we had a lot of retrospective data showing potential survival benefit with surgery, and everybody thought there was selection bias. And so we needed to do this in a prospective manner. And so since I've been in practice, that's kind of been the discussion. And we know that that trial ended up showing no survival benefit with surgery. And I know we'll talk about a couple other trials. And so to be honest, I kind of thought this topic was done, that we kind of had figured out that surgery for metastatic, and you talk about de novo, that's important, kind of differentiating those things, was over. And I'm surprised to see that we really are still talking about this. And there potentially are some patient populations that benefit from surgery. So I won't go into that just yet, but I would say that for the most part, I'm operating only in palliative cases or cases where my medical oncologists are sending these patients to me. But I'm always sort of looking for what the data is on the patients who should be operated on appropriately. And I think it's an important topic for us to talk about because our listeners need to know that.
So 2108, I always called it the CMACON trial because CMACON wrote the protocol on it. And I agree, it was an early clinical trial that I was the PI on in my institution and really concentrated on enrolling patients in it. But again, it's a small number of patients. So in all, there were fewer than 300 patients enrolled in this trial. So Ellie, you have the, I guess, advantage, disadvantage, depending on how you look at it, as you've come into practice in the era of maybe it's not solved. I'm with Carla. I thought this was put to rest, but it's not. So Ellie, how do you approach this? And how do you figure it out?
Obviously, patient by patient, clear cut. I was also taught in my fellowship, really surgery is not making a difference here. Systemic treatment is their mainstay of therapy. Surgery is palliative. That's what I was taught. And then there are these newer studies that said maybe in younger patients, maybe in patients with hormone positive, HER2 negative, under 55, oligometastasis, bony metastasis. I've gotten pressure from my medical oncologist to operate on those patients. And, there are some studies that show that's beneficial. And how I navigate it early is I bring these to tumor board. I bring them to multidisciplinary discussion so that it's not just a solo decision, because it can go so many ways.
I want to follow up to that because I think all the things you said are correct. And you've talked about we all practice in different parts of the country. If you have a patient like that, are you doing bilateral mastectomy with reconstruction? Or are you saying, okay, well, I'll do a mastectomy. I'm only going to take, or a lumpectomy. So you will kind of limit the extent to surgery.
Correct. Yeah. Well, then if you do the lumpectomy, are you doing the radiation? If you're going, is it go big or go home? If you're doing it and you're saying, you know what, I am operating on this patient. It's a young woman. Why are we, look like you're hesitating. Maybe I radiate, maybe I don't. But why would you not?
We're going to give them benefit of doubt. So we're going to try and throw things at them that can hopefully control this. So yes, there haven't been a lot of these situations in my early practice, but I do remember, yes, we're not doing a bilateral mastectomy, no recon.
So you will say mastectomy with no recon, though. Devil's advocate, right? Because what we're talking about in some of these patients is potential cure or longevity, especially the young patients with ER-positive disease and oligometastatic. There appears to be some potential for that. So not doing reconstruction, I'm not saying you have to do it, but that becomes a tough discussion, especially for a young patient who might have a unilateral mastectomy and a contralateral breast.
But that's at least what my plastic surgeons have come back with when I send the referral for them to have the discussion. But what if it gets infected? What if the tissue expander has a problem? That's going to delay their treatment. So at least in my early practice, that's how we've treated that, is like, get the cancer out, get it done, try for curative intent. And then if she's good, maybe we could consider those options down the road. But again, this has been like 1 or 2 patients in my practice. So it hasn't been a huge number.
For me, there's like 2 categories, right? There's people who come in and this is just palliation. They have a fungating wound. It's painful. It's gross. And wound care is a challenge. And if they can handle a surgery, that could be one discussion, being very clear that this may not change their overall survival or disease-free, just survival at all. I mean, they still have disease. And then I think where it gets trickier is for the people who've had a really good response in the category, Ellie, that you have talked about. And you also emphasize this is totally multidisciplinary. Surgery is not the cure, but it could be one pillar of something that may benefit a small segment of these patients.
Well, and I have a really fun example of a classic California patient too, who was probably stage 4 when she presented, but doesn't believe in chemo, doesn't believe in radiation. She has a fungating mass with little skin metastasis around it that are luckily kind of next to the nipple. Refuses PET scans, refuses CTs, and really surgery is her only option. So that was a really challenging patient where surgery was the only thing she would accept. And I had to have that discussion with her. I said, this is not the cure. And it was HER2 positive, of course, too. So totally could have been fixed with HER2 directed therapy. But that was and again, I brought it to my tumor board. I had that discussion, but talking to the patient about before and saying, this is not going to cure you. You need to do the other things. That was a really hard patient early in my career. And we did end up operating because that was the only thing she'd accept. And I just got a phone call this week that, oh, look, she has a new spot that popped up. So now she's willing to accept HER2 therapy.
Right. But I think that what you raise is a really important point. And I think that we've all had these patients in our careers. And I think patients have to be comfortable with what they do, but we also have to be comfortable in how we are treating the patient. And I know in my career that I have told patients that I'm not the right surgeon for them because I am not comfortable doing what they want done. And I'm not telling them that they cannot have it. I'm just telling them I'm not the right doctor for you. And I explain, you as the patient have to be comfortable, but as the surgeon, I also have to be comfortable and think I'm doing the right thing. If I really think it's the wrong thing, I'm just not the right doctor for you. Here's names of 5 other doctors I want you to be comfortable and I want you to be taken care of. I'm just not the right person for it. And I am comfortable doing that, especially at this point in my career.
That's been one of the hardest lessons I've had to learn starting out, is that I'm not the surgeon for everyone.
Right.
And telling them to get like that is hard.
I mean,
say.
Michael has that discussion once a week with this patient.
I just don't operate anymore. I just refer them all out. It's unless it's DCIS, I'm not doing it.
Yeah.
You know, it's interesting though, being old, to watch how you sort of evolve, and you learn this with time, that your greatest lessons are some of the mistakes that you've made. And I used to early on just double down. By golly, they're stage 4. What are we doing here? I can't change their survival, and I don't think there's any data really that's beginning to suggest that yet. We may get there with certain disease types like HER2 or whatever else. And the open wound patients are easy. We're all going to do that.
What about radiating those patients?
Well, and I think we should.
I don't know that you say we're all going to do that. Like, that's standard. We radiate. I mean, I would like to tell you that we don't see any fungating breast cancers. Unfortunately, we see a fair amount. Some come in bleeding. We'll radiate.
But the fact is, if that doesn't work, then you're still going to revert to surgery. I think the difficult ones are, say, an inflammatory breast cancer that gets a great result on chemotherapy, still has metastatic disease, and the breast looks like it's resolved. And I have made the mistake on more than one occasion to where I let that go and fully regret it, because in short order, they've got skin nodules that are spreading around. They're painful. Problems develop back in the breast. And so I got fooled thinking that I'd controlled the breast, and I hadn't. And I think that there are certain circumstances that even if it's not immediate local control, there can be benefits for local control down the way by just getting ahead of it. And I've learned that lesson.
And I also think having excellent expectations with that, saying, even if you're at this spot where we're able to remove the breast tissue now, that might buy you time, but that does not prevent a recurrence, even local regional at the breast. It can still happen. And I think being able to have those expectations is great. And it also may give that person a delayed local regional recurrence. We don't exactly know all of that.
We seem to be the ones sometimes having to have that conversation that and I don't want to just disparage the medical oncologist, but sometimes it's like, I've got something for that. I've got something for that. And it's oligometastatic disease. Well, it's actually 4 lesions, but we're going to call it oligometastatic disease. And they keep going and going and going. And sometimes we just have to say, stop. We need to kind of re-level here as to what we're dealing with. I'm certainly not going to change your survival outcome with this, but there are things that I can offer you that may change your quality of life or whatever, or maybe keep you from having to deal with skin nodules chased around your back or things like that. It's a difficult conversation, and sometimes we're the ones that are having it.
Oligometastatic, how do we define that? Because you said 4 lesions, and I think there was a paper that just came out, and I think they defined it as 5 or less than 5. And that's the tough thing, because oligometastatic, there are some data that there is a survival benefit. And the problem is we don't even know how to define them. We don't know how to code for these patients. So it's hard to kind of look back at registries and understand who those patients are. But I just wanted to point that out so we're all talking about the same thing. But 4 metastatic sites is, I think, considered oligometastatic disease.
It is.
Which is crazy.
So let's just go back, because there is real literature on this. So Carla, talk about the 2108 trial and the results for us so that everyone's on the same page.
You're listening to the Next Breast Thing podcast. We'll return in a moment after this brief message from our sponsors.
What do surgeons want? Not having to wait on nuclear medicine makes our day much more efficient.
With MagTrace, we can start now at 8:30.
It decouples those appointments from radiology and helps with patient experience also.
The efficiency that is afforded has honestly revolutionized my day.
Hologic, redefining breast care from screening to surgery. MagTrace is a registered trademark of Hologic. Julie Margin-Taylor, Crystal Gallagher, and Michael Boland were paid consultants for Endomag. For MagTrace indications, warnings, and precautions, please reference the instructions for use at eifu.endomag.com.
Breast cancer recurrence doesn't wait for symptoms. Signatera is a tumor-informed circulating tumor DNA test
that detects molecular residual disease months before imaging. From neoadjuvant response to long-term surveillance, get unparalleled insights to inform next steps. Signatera is backed by Medicare coverage and more than 175 peer-reviewed studies. Learn more at natera.com/Signatera.
And now, back to the next breast thing.
Carla, talk about the 2108 trial and the results for us so that everyone's on the same page.
So I don't have it in front of me, but I know we started enrolling in 2013 or 2014, and then it was published just a couple of years ago. So
as you said, 2022.
Yeah. One of the things that I remember is there were a lot of patients that didn't qualify for different reasons. So it was definitely one of those tough studies to recruit patients or kind of identify patients who would qualify. Partially because like you said, only 6% of our patients, thank goodness, have de novo stage 4 disease. And so the basic outcome, these patients were randomized to either undergo surgery or definitive local therapy with lumpectomy and radiation, which I remember thinking was interesting, or systemic therapy alone. And the big outcome that we were looking for was there was no survival benefit. And there was, I think, improved quality of life, which I want to point out that those are always important things when we look at clinical trials, and improved quality of life without surgery.
At 30 months in the study, quality of life was similar between both groups.
Did it go down and then come back up?
Now you had to survive 30 months to get there. So
that's what I was thinking. I was like, there's a little bias there, like that first year versus you've made it 2.5 years.
Right. I think that there's a lot of bias along the way in this study. So I just wanted to point that out.
Let me ask that question to both of you that enroll patients. Did you find that there was bias in patient enrollment?
Yes.
The 30-year-old is less apt to be moved in that direction?
Yes. I think that these trials from the get-go have bias. So unless you are enrolling consecutive patients, every single patient with de novo metastatic disease gets enrolled in this trial, then there's bias. Because sure, you can put the 60-year-old in, but are you putting that 30-year-old woman in? Or are you putting the 90-year-old in? I think that we have bias, although eligibility, I don't think, went up to 90. But we do have bias in who we offer or discuss. Let's say we do discuss it with every patient. There is our bias in how we say things and how it's presented. Carly, you look like you're chomping at the bit to say something.
I think all those things are true, but that is the reason why we need clinical trials and why those of us who
100%.
are engaged in it have to enroll patients evenly. And obviously we want to be ethical, and there's so much rigor that goes into opening clinical trials, but we don't answer these questions if we go through all this work and then we go, well, there is bias, so I'm not really sure if I understand that. I remember learning that in fellowship is, yes, you're going to have a bias, right? That was a huge discussion with the Z11 trial, right? Well, I'm not going to omit axillary lymph node dissection, but it's like, you have got to approach every single patient the same. It was a hard trial, and I just want to give credit where credit's due for putting that trial together and doing the work, because it is good data, but it
was new
hard
to me. Honestly, I kind of knew about it, but I hadn't really read it. And one of the things that I really appreciated in this manuscript was saying like, hey, the intent was to enroll 660 people. We weren't making it, and it was supposed to be consecutive. And they had to go back and revise and be like, okay, the way we had this out for just enrolling everyone consecutively isn't working. How do we still get some meaningful outcomes out of this? And then they explain that. I think that's really big. Sometimes when these negative findings are in studies, that's real world. We're still going out there and trying to answer a really important question. And just like real life, how are we having to revise things along the way and getting good information?
So this study enrolled from 2011 to about 2015, as I said, was published in 2022. The way the systemic treatment of patients then is vastly different than the systemic treatment of patients now and the outcomes. And I think in 2022, I was like, okay, we were so excited to see the trial results from this because we had enrolled in it, but also it's a difficult situation. But when you look at it, showed that patients who were in the systemic treatment arm alone, they did have a higher rate of local regional progression versus the surgery group, but the overall outcome and survival was the same. I think that was really the takeaway message. And that's the discussion that I have with patients. I mean, I do think that this is the best evidence that we have. There was a big study, a Turkish study that I think was published prior to this. And I remember hearing it at one of the conferences.
San Antonio. We presented the Turkish one and I think the India one at the same San Antonio conference. Yeah, I was there. Those were interesting because it's such a different patient population.
Correct.
And I think those did not show better survival, although the Turkish study
one.
is the one. Yeah. And that's where it's those young patients younger than 55, estrogen receptor positive, oligometastatic. But I can't remember if those patients didn't get HER2 directed therapy. But again, it was one of those things, how well can we apply these results to our patients here in the US where therapies are so different? What I didn't realize is there's a clinical trial, I think it's enrolling now, for HER2 positive metastatic breast cancer patients out of Memorial Sloan Kettering. And so I think the HER2 space is so interesting. And one of the things we've alluded to, right, is systemic therapy is the boss here. We as surgeons like to kind of be in charge, but systemic therapy is the most important thing for these patients, always, forever.
Impacts survival.
Absolutely.
100%.
And so anytime we look through this, we look through the lens of that, right? So Ellie, you talked about if an infection happens, we don't want to sort of delay therapy. In many of these patients, it shouldn't delay a lot of the therapies that they're getting. Maybe if it's ER positive, patients can be on anti-estrogen therapy and have an infection. They can have an infection and get anti-HER2 directed therapy. I think for the most thought, they can't get chemo, but most of these patients are not getting systemic chemo and getting curative breast cancer surgery.
So, Susie, you have a 35-year-old woman, bone-only mets, not anything else, 2 lesions that we see in the bones. She has a 3-year-old and a 5-year-old. How do you treat her? What do you tell her?
Yes, that makes my heart bleed. And we still have to treat the biology of the disease. And sometimes, this was really my first year in practice, I still remember the patient's name, the entire situation, everything. And that was so hard, but she was dying. And it was more important to be honest with her about that for what her life looked like, feeling better than giving her a lot of treatment that she would not be enjoying those times. So that is an incredibly hard conversation to have. So one of the things is we got to be really objective with the biology of the disease. The way you said it, I think it is reasonable to look that this is not standalone curative. It is multidisciplinary, and there may or may not be a survival benefit. And in the particular patient you presented to me, I would present it in that way of we can do all these things and there may be a benefit. But even with the Cochrane review in 2025, they weren't showing an overall benefit, and they added in the 3 new trials on there. And so people are smart. I think we can have big discussions with them.
I think what I got off of was this idea of survival or nothing.
Right.
And you've got somebody that's an ER positive patient with bone disease. They may be your patient for another decade.
Metaviver.
Or longer.
Yeah. And so I probably can't change your survival. But, what are we going to do? Are we going to be bringing you in all the time and monitoring this thing in your breast and always worrying about it? And invariably they think it's bigger and they're coming back in and they're stressing about it. That maybe a quick hour-long surgery in the operating room to remove the mass, sometimes you get differential responses. What happens in the breast may not be what's happening in the bone. So, in a situation like that, I'm much more inclined to treat the breast not for survival, but for some of the other secondary benefits that you're going to get.
The local regional progression and allowing them to have more of those times without that progression, I think that's really significant.
Before we close, let's get our takeaways. Ellie, your takeaway.
Hearing you guys talk about learning to say no to a patient and maybe offering second opinions. That's a muscle that I'm going to have to work out as my career progresses. And it's just a good reminder to kind of remember the stuff that comes with experience. And to all those newer surgeons out there, like that is one of the hardest parts I've come across, is learning when to say, hey, you should get a second opinion.
And you're not abandoning the patient.
Right.
You'll help them get another appointment. I think that we're actually doing them a favor by saying we're just not the right doctor for them. That's okay. And it does take time to develop that, without a doubt. Carla, your takeaway?
I don't think we have a lot of issues with people operating inappropriately for metastatic breast cancer. I don't think that's a controversial topic, so I don't want to belabor that. I think the take-home message is that, yes, right now, surgery overall does not offer a survival benefit, but stay tuned and the jury may still be out, and pay attention to some of these trials. And in 10 years, we may be speaking differently about this. So who knows? Maybe we'll be talking about it next year at the meeting.
But how cool is this? Even when we think we've solved a problem, systemic therapy has gotten so good that it's an issue again, and we don't know what to do again. So
it's a good problem to have.
Right. It's a great problem to have. Susie, your takeaway.
So probably not survival benefit, but there may be a local regional benefit in select patients. And I am so excited to continue to see where precision-based cancer treatment is going to bring us into the future.
Oh, I like that. And Michael, we'll let you close it out.
I'm going to piggyback a little bit off of what Carla and Susie said, in that I think the precision medicine is maybe a hope here, and maybe circulating tumor DNA may give us a little bit of insight as to who's responding systemically, and maybe a little bit of insight as to who we should and shouldn't treat. None of our studies have shown that to this point. They've really hadn't looked at circulating tumor DNA. So maybe that's something that'll give us a peek behind the curtain.
Look at you, Michael, combining different episodes into the topic. So this is a great topic. I have to say, I was a little hesitant, but you guys were right. And Carla, you were spot on that it really is such an important topic. And even though it's a minority of patients, it's real. And when we see it, we feel the pain for them, and we want to do the right thing by them. So, to all of our listeners throughout the entire breast community, we're so excited you've joined us on this journey once again. And we'll see you next time on the Next Breast Thing podcast.
We look forward to connecting with you on the next episode of The Next Breast Thing, a podcast by the American Society of Breast Surgeons for the breast community.
Also, join the conversation on our Facebook group by searching the Next Breast Thing podcast group on Facebook.
Finally, the content within the Next Breast Thing podcast represents the views, thoughts, and opinions of the co-host, and may not necessarily reflect the views, thoughts, and opinions of the American Society of Breast Surgeons.
Until next time, this is Carla,
Ellie,
Michael,
Susie,
and Susan. And always remember, if you're part of the breast community and can't seem to find the answers, this is the Next Breast Thing.